Good afternoon. This lesson is targeted for primary care providers that are prescribing PrEP or pre-exposure prophylaxis for HIV in outpatient settings. Surprisingly, 1 in 3 primary care providers are unaware of what PrEP is. I'd like to mention that there aren't special certifications that are needed to prescribe PrEP. However, there are additional available courses online. Please note throughout this lecture, PrEP and Truvada will be terms used interchangeably. The objectives for today are to define the purpose and goals of PrEP therapy. We're going to identify contraindications for PrEP. We're going to identify patients who benefit from PrEP therapy. We're going to discuss PrEP prescribing and monitoring guidelines, and we'll identify side effects of PrEP. A prescribing checklist designed by Gilead will be provided along with case studies. What is PrEP? PrEP is a daily oral medication known as Truvada, an antiretroviral medication that prevents the contraction of HIV for high-risk patients. High risk is defined as men who have sex with men, multiple partners, inconsistent condom use with partners who inject drugs, patients who inject drugs or steroids, especially those who share needles, syringes, cookers, or other equipment used to inject drugs, and patients with recent STI transmission, patients in a relationship with an HIV-positive partner, also known as serodiscordant relationship. Daily adherence to PrEP reduces sexual transmission of HIV by 90%, and it is important to note that the risk is lowered even further with combined use of condoms. PrEP also reduces IV drug use transmission by 70%. This slide is important to keep for your reference. This will allow for you to screen patients for eligibility for PrEP. Screening questions such as, do you have sex with men, women, or both? Do you use protection? How often? If you deem a patient to be high risk, you may ask, would you be interested in prophylactic treatment such as PrEP? It's important to also know that PrEP is okay in pregnancy, especially for partners who are serodiscordant. At this time, PrEP is considered safe during pregnancy, as we do not have conclusive data that PrEP causes birth defects. We do not, however, have sufficient data for adolescents prescribing, and therefore we should be using it with caution in this patient population. So why is PrEP so important today? PrEP is so important today because there is an estimated 1.1 million Americans that are living with HIV, of which 1 in 7 do not know their status. There were approximately 39,513 HIV diagnoses in 2015, which was a decline of 10% from 2010 to 2014. But it's important to note that gay, bisexual, and other men who have sex with men bear the greatest burden by risk group, representing an estimated 26,000 of these new HIV infections. I've provided this slide for your future reference when understanding the target populations while prescribing. Again, the overall population experienced a decline of HIV diagnoses from 41,000 to about 37,000 between 2010 to 2014. To highlight the importance of PrEP, among gay and bisexual men that are white, annual infections declined 11%. But among Black, African American gay and bisexual men, infections remain stable. Among Latino gay men, infections increased. So it is important that PrEP is offered to all patients who are inquiring and meet criteria. And don't forget to ask these patient populations that are highly affected by HIV. Once a patient is deemed eligible based upon risk factors, it is essential to test the patient for HIV and hepatitis B before they start PrEP. Patients who are HIV positive and on PrEP develop resistance to this medication, which makes it more difficult to manage with the antiretroviral combination HIV medications. Hep B is also treated with antiretrovirals. It's not cured, but it's essential to know their status. Therefore, a patient must be closely monitored and followed in the early prescribing stages and HIV must be tested frequently. Patients who test negative for HIV but have experienced symptoms of HIV, such as flu-like or mono-like symptoms, within the last 6 weeks should not be prescribed PrEP. Evaluate their medication list for drug-drug interactions or nephrotoxic medications, and evaluate substance abuse and mental health to determine if this would possibly be a barrier to medication adherence. Address the patient's understanding of PrEP therapy and stress the importance of daily adherence, as this is an essential component to PrEP therapy and preventing contraction of HIV. Furthermore, evaluate partner status, information, and housing, determining if the insurance will cover PrEP or if they'll need additional assistance for coverage through case management. PrEP, again, is contraindicated for confirmed HIV positive patients. Patients also who have a poor kidney function with creatinine clearance less than 60 are also contraindicated patients, and patients who are unable to adhere to daily medication should not be prescribed PrEP. It is therefore important to discontinue prescription for patients who come back for testing and are confirmed to be HIV positive, who develop kidney disease or low creatinine clearance, and risk reduction. It is also important that you understand that pregnancy is not a contraindication. And as a reminder, there's very limited data on adolescent prescribing, so please use with caution. Once you've evaluated eligibility and contraindications, PrEP can be prescribed. But it's important to note that PrEP should not be given with 90-day supplies at the initial visit. It is nephrotoxic, for one, and risky for patients who are HIV positive. So therefore, it's important to only prescribe a 30-day supply at first. It's also important to remember that HIV is not always detected at the initial visit, and therefore, you must have the patient return for HIV testing and, again, renal function testing. Once they return after 30 days, you can give an additional prescription for 60 days. Once they return again and you repeat testing, then you can move to a 90-day supply. The patient should be returning every 3 months for testing. Again, risk reduction services should be offered for patients. Side effects from PrEP are common of nausea, headache, abdominal pain, and weight loss. These should resolve within the first months, and you can advise your patients to take their medications with food. Does anyone have any questions? So at this time, I'd like everyone to take out their prescribing checklist that I provided for you and PrEP guidelines. So today we're going to be going through one case study that may be common in your practice. And I'd like to just discuss all of the elements that you will find on your handout that are the prescribing checklist for Truvada, along with the eligibility criteria from the CDC. In this case study, there's a 25-year-old African-American male who comes into the clinic inquiring about PrEP. He is sexually active with men, reports inconsistent condom use, and sometimes has partners that are IV drug users. Furthermore, he denies any flu-like or mono-like symptoms. He, in his most recent labs, which were a few months ago, had excellent kidney function. Now, based upon your checklist, the qualifications for PrEP, as of now, he does qualify. He is a high-risk patient who is deemed healthy as of now and has no other comorbidities or nephrotoxic medications. What labs would we be drawing for this patient? First and foremost, we need to know the kidney function. So we need a creatinine clearance. We would do a CMP. We would do a CBC. We would test for Hep B, and we would test for HIV. And what else would we do besides labs? We would ask for any comorbidities such as substance abuse and mental health concerns, along with housing and means to fill prescriptions and any barriers for medication adherence, for daily medication adherence. The patient would need to return to the clinic within 30 days. So we would give a 30-day supply to this patient. Again, after this 30-day supply, they would return. We would repeat HIV testing. We would repeat renal function. Now, I'm going to ask a few questions based on this case study and your checklist. This patient comes back and is HIV positive 30 days later. What do?
You stop PrEP immediately.
Yes. Patient comes back with a creatinine clearance less than 60.
Stop PrEP immediately.
Okay. So these are things that we definitely need to remember walking away from this lecture and case study. Again, I am very confident that with this checklist, with the guidelines, and the PowerPoint that I've provided with you, you will be able to provide basic guidance to your patients within the primary care setting. Again, there are additional courses that you can find online, and there are no certifications or special licensing needed to prescribe PrEP.